Next up is Brian Goldstein, who will talk to us about transcatheter pulmonary valve replacements in adults with congenital heart disease. This is occasionally, even though the tricuspid valve is famous for this, tends to be the forgotten valve in adult symposia. So, Brian, please refresh your memory.
Great. Thanks very much for the invitation from you, Yves, and the other program leaders. It's really an honor to be here at this really important symposium today. I do have some disclosures. I think most importantly, we'll focus on patients with congenital heart disease, which is a little unusual, but I think important. As many folks in the room will interact with these patients rarely, but at times, and knowledge and access to folks with more knowledge will be helpful. So it's worth a brief refresher on the history of transcatheter valve replacement. This is Philippe Bonhoeffer, who in Paris in the year 2000 implanted the first successful transcatheter heart valve, which was a pulmonary valve in a child with congenital heart disease. It wasn't for 2 more years that Alain Crébillé implanted the first transcatheter aortic valve successfully in the same institution. So if one evaluates patients with congenital heart disease, what's clear is that survival has increased dramatically over the last several decades, such that now adults represent 2/3 of those patients living with congenital heart disease. So this population is really quite important to understand. And although survival has improved, morbidity is quite impressive. 1/3 of patients over a 1-year span with severe congenital heart disease will be hospitalized from these data out of Quebec, and 20% of patients with mild or moderate forms of congenital heart disease will be hospitalized in a 1-year span. That's a high incidence. Tetralogy Fallot, which is one of the more common forms of congenital heart disease and something we'll be focusing on today, has low mortality over the first 2 decades of life, but the hazard of mortality increases substantially into the 3rd decade. And if one evaluates tetralogy Fallot versus other forms of congenital heart disease, the median survival is less than 40 years of age. That's impressive. So why does this happen? If we start at time 0, which is transannular patch repair of tetralogy, the most common type of repair, this happens early in childhood. And with VSD closure and the transannular patch placement, there is the development of right bundle branch block and an increase in the QRS duration. There's also the presence of pulmonary insufficiency. Over the first 2 decades, with progressive pulmonary insufficiency and the resultant dilation of the right ventricle, there is further increase in the duration of the QRS complex. At about 180 milliseconds, there's a significant increase in the risk of ventricular tachycardia and sudden cardiac death. If we overlay the survival curve of tetralogy, it becomes clear what the manifestation of sudden death is really all about the underlying physiology and its progression over the first couple of decades. Moreover, in addition to the QRS changes, there's substantial right and left ventricular interdependence such that LV function reduces substantially with RV dilation. Tetralogy is not the only form of right ventricular outflow tract dysfunction in congenital heart disease. There's other patients too, such as those with valvular pulmonary stenosis, truncus arteriosus, the Ross procedure, after aortic valve disease, both congenital and acquired, double outlet right ventricle, and many additional rarer forms of congenital heart disease. The timing of pulmonary valve replacement ultimately is critical to best outcomes, just like we've heard in mitral valve disease and aortic valve disease. And our indications, our guidelines are really problematically varied substantially across the different societies, both in the US and beyond. So we need to understand not only when to do this, but what we can do. I want to focus now on the current state of transcatheter approaches to pulmonary valve replacement. About 20 to 25% of patients with congenital heart disease have anomalies affecting the right ventricular outflow tract. Those to the right of this line are the minority and are repaired with RV to pulmonary artery connections, tube grafts, conduits. These patients typically manifest with conduit dysfunction in the form of either stenosis or mixed stenosis and regurgitation. They represent about 15% of patients that are managed with balloon-expandable transcatheter pulmonary valve technology. The brief case to show a patient who has complex conduit obstruction with both involvement of the distal conduit and proximal bilateral branch pulmonary arteries, as well as proximal RV to PA and anastomosis conduit obstruction. This patient was managed with placement of a unilateral pulmonary artery stent, a dilation through the side cells of that stent to open up, a connection to the contralateral pulmonary artery, second stent placement to form a bifurcation stent, treating the distal conduit and PA stenosis. And at that point, a pulmonary valve was able to be placed proximally in the proximal obstruction, thereby relieving obstruction proximally and distally and restoring pulmonary valve competency. We've learned other things with balloon-expandable technology. Frame fracture, as is well known in the aortic world. Frame fracture facilitates the implantation of a larger transcatheter valve-in-valve implant. We've also learned that moderate or severe tricuspid valve insufficiency does not need to be managed surgically. Simply replacing the pulmonary valve in a transcatheter approach will improve the TR grade by at least 1, if not 2, scores in both patients with moderate and severe tricuspid insufficiency. And the outcomes late after transcatheter pulmonary valve replacement in these balloon-expandable constructs are quite good. 72% of patients are alive at 10 years of age without explant or reintervention. On the left half of this diagram is what's really changed in the last couple of years. These are patients typically with tetralogy of Fallot who have pulmonary insufficiency and represent the majority of patients with RV outflow tract dysfunction. And the challenge for both academics and industry partners is managing the very heterogeneous anatomical subtypes of RV outflow tract dysfunction after early surgery. In 2001, we really heralded sort of the new era for us in transcatheter technology with the Medtronic's Harmony transcatheter pulmonary valve and Edwards Altera adaptive pre-stent mated with a standard SAPIEN 3 valve being cleared by FDA. So I'm going to show a couple of case examples. This is a patient who underwent Harmony transcatheter pulmonary valve placement, a 24-year-old who had a freely leaky pulmonary valve with the dilation of the right ventricle and symptoms. And here you can see the fit analysis provided by the company demonstrating the relationship between the patient-specific anatomy and the valve. Here is an overlay of what they think it may look like. And here is the invasive angiography before and then after pulmonary valve replacement. These are pretty quick procedures, under an hour now, to achieve pulmonary valve replacement. And this is a nice landing zone for future balloon-expandable transcatheter valves when this prosthesis fails. This is 6 months later showing a remodeling of the right ventricle with no pulmonary insufficiency or stenosis. Case from the Edwards Altera adaptive pre-stent in SAPIEN 3 is a 56-year-old male with tetralogy who had stage repair, has a severe pulmonary insufficiency and RV dilation, who is symptomatic. This is a baseline angiogram showing the pulmonary insufficiency and the complex PA anatomy. After placement of the Altera adaptive pre-stent, you can see an unobstructed pulmonary outflow tract, but no valve competency. And then following deployment of a balloon-expandable SAPIEN 3 valve inside of the Altera adaptive pre-stent, there is now restoration of pulmonary valve competency without issues. The midterm outcome of these valves are still pretty new. These are just 20 patients here in the very early feasibility study showing that at 5 years the valve works excellent without insufficiency or obstruction. And here at 1 year in a larger population of patients who underwent valve placement with either the smaller or larger Harmony prosthesis, greater than 90% freedom from PR, PS, or reintervention. Early outcomes from Altera and SAPIEN 3 are also quite good, although the population of patients studied is limited to these 15 patients that are in the literature. There's been nearly 1,000 implants in the native RV outflow tract in the 2 years since commercial approval of these valves across the world. We had the opportunity to be a part of the very early experience, being the second commercial site launch for both products. And here's our experience, which is 52 patients who were referred for evaluation. 36 patients were treated with Harmony, 6 patients with the Altera product, 3 were able to undergo balloon-expandable approach, and 7 were referred for surgery. And this yielded a number that was pretty good. 87% of patients referred were able to be treated with a transcatheter approach and were able to avoid cardiac surgery. But in the absence of a mandated registry, we await large-scale outcomes data. This is being worked on actively. And indications for pulmonary valve replacement need to really catch up with clinical practice. So how do we best care for ACHD patients with RV outflow tract dysfunction? I think it's important to recognize that survival is improved with ACHD referral center care. Only about 40% of congenital heart patients remain in congenital cardiac care by the age 18 to 22. This is a real problem for our field. And more than 50% of ACHD patients have a lapse in care of more than 10 years, which was associated with an 8-fold greater need for an urgent intervention upon presentation. So my sense is it's critical to partner with a team-based, multidisciplinary, accredited ACHD program to facilitate easy transition from pediatric cardiology care, as well as referral from general cardiology to promote lifelong congenital heart disease care. This is just a plug for our team. Arvind Hoskapel in the center here leads this group of 3 physicians who are all outstanding, and there's their email address to get patients plugged into the care they need. Thank you so very much. I appreciate it.
Thanks, Bryan.